Hello, everyone. Welcome to tonight's CAEP National Grand Rounds. I'm Hassan Abdullah, a resident in the UBC Kelowna Rural Family Medicine Program. I am interested in emergency medicine in both the clinical and academic aspects, and I'm very pleased to present today's topic and speakers. Our presentation today is entitled Post-COVID Condition, the syndrome previously known as long COVID, what ED-MDs need to know, and it will be presented by our expert speakers, Dr. Grace Lom and Dr. Maeve Smith. The talk will be moderated by myself and Dr. Eddie Lang. Please pose your questions in the chat as the talk progresses so that they may be answered at the end of the talk. These are the conflicts of interest. Moving on. So we're talking about the post-COVID condition. Post-COVID condition is a condition which affects a proportion of people who have had COVID-19 and causes persistent cardiopulmonary and CNS symptoms. It is also known as long COVID amongst other names. There are more formal criteria for PCC, which will be discussed by our guest speakers. PCC is a scary experience for many patients. Symptoms include shortness of breath, chest pain, and unrelenting fatigue, amongst a myriad others. These physical symptoms can be debilitating for life and in turn have profound mental health impacts. Many patients turn to the emergency department to help manage and reassure themselves that there is nothing life-threatening to worry about. For the ED physician, this can create an uncomfortable dilemma where they have to decide on ruling out critical diagnoses that share similar symptoms, such as PEs and ACS. As an example, pilot data from Calgary shows an uptick in patients being investigated for PEs who in fact likely are presenting with PCC. ED physicians have to balance the risk of over-investigating PCC with the risk of overcalling PCC. Our speakers, Drs. Lom and Smith, are experts on the topic, having led the way with their research and clinical work. We appreciate them taking the time to educate us on the topic and their advice on how to navigate the decisions we have to make in the emergency department. Dr. Grace Lom is a new assistant professor who joined the Division of Pulmonary Medicine at the University of Alberta. She and Dr. Smith, with support of their division, launched the first COVID-19 clinic in Alberta in June 2020. She trained in the University of Toronto in the MD-PhD program, where her PhD work focused on basic science research on autophagy and intracellular immunity against Listeria monocytogenes, resulting in nearly 20 publications on the topic. She then completed her residency in core internal medicine and adult pulmonary medicine at the University of Alberta and went on a year-long fellowship in adult cystic fibrosis in Vancouver. Over the last 2.5 years, she has launched her research program in cystic fibrosis and has received local, national, and international recognition for her work. Dr. Maeve Smith is an assistant professor in the pulmonary division in the University of Alberta. She graduated from the University of Edinburgh and continued to complete her training in Edinburgh, UK. She has a specialist interest in lung infection, particularly bronchiectasis, and has published widely in this field, including conducting trials in nebulized antibiotics and airway clearance. She has received research awards from the Scottish Thoracic Society and British Lung Foundation. She is a co-author of the recent British Thoracic Society National Guideline for Bronchiectasis and currently runs the Bronchiectasis Clinic in the University of Alberta. She's also a member of the American College of Chest Physicians Chest Cough Expert Guideline Panel. She has spoken regularly at international as well as national and local conferences on bronchiectasis and cough. Together with Dr. Grace Lom, she is the co-director of the post-COVID-19 clinic at the University of Alberta Hospital. She is also the co-chair of the AHS Medicine SCN Long COVID Working Group and has spoken on aspects of post-COVID both provincially and nationally. Dr. Eddie Long is a professor and department head for emergency medicine at Cummings School of Medicine, University of Calgary and Alberta Health Services. His areas of interest are knowledge translation, evidence-based medicine, and operations research. Dr. Lang has served as the chair of the CAEP Leadership Committee from 2017 to 2020. Dr. Lang is also an award-winning educator, having received recognition at both the university, national, and international levels. He also serves as senior editor of the Canadian Journal of Emergency Medicine, associate editor for both ACP Journal Club and the International Journal of Emergency Medicine, and he is a member of the Canadian Task Force on Preventative Healthcare. Dr. Lang has chaired the CAEP conference in 2018 and is appointed as the scientific director of the Emergency SCN in Alberta. And without further ado, we'll begin our talk and welcome Dr. Lam and Dr. Smith.
Good evening, ladies and gentlemen, and both Dr. Lam and myself, Grace and myself, would like to thank the organisers for the opportunity to speak to you this evening, to share some of our experiences with the post-COVID patient population with you, as well as understanding some of the challenges that we're facing. And we just have our disclosures on our next slide. And really, the objectives of our talk are to try and help understand some of the current challenges in the way we are learning how to define so-called long COVID or post-acute sequelae of COVID-19 condition, as well as discussing some of the more common symptoms and complications of long COVID, as well as discussing some management strategies for some of these more common long COVID symptoms that are perhaps more likely to present and turn up in your emergency departments. So, it is now 20 months and 6 days since the WHO declared COVID-19 a pandemic. And as we all know, it has devastated the world with over 250 million cases and over 5 million deaths worldwide. And here in Canada, our case numbers also continue to rise. It's shown in the next slide. Our case numbers here are continuing to rise. And along with that, there is also a growing realization that the toll of COVID-19 extends far beyond the acute infective phase, and that it is also associated with significant long-term morbidity. We all know that acute COVID-19 infection is an acute multi-system inflammatory condition. And certainly there are direct long-term consequences that can be experienced from the acute infection. For example, from a pulmonary perspective, there may be fibrosis, chronic respiratory failure, persistent dyspnea as a complication. But also, as shown in the next slide, there can be complications and long-term consequences from the management of acute COVID-19 as we use antiviral drugs, novel immunomodulatory therapies, some with known potential long-term causes or consequences and other with unknown consequences. And there is also now evidence to support a separate patient population that suffer from persistent symptoms or complications long after they have been deemed recovered from the acute infective phase. But really, who is experiencing long COVID? Who gets long COVID? And so this question is actually a question that I'm going to pose to, that we're going to pose to you, the audience, tonight in the first of our Ask the Audience questions. And so I'd ask you to select an option from 1, 2, 3, or 4 from this slide to answer who you think typically will suffer from post-COVID-19. And if you could start voting now, that would be great. So is it patients who have been hospitalised with acute infection, or patients who were hospitalised and required ICU with acute infection? Or is it patients who did not require hospitalisation with acute infection? Or indeed, are we seeing post-COVID-19 condition in all of these patients? So we'll wait for your answers to come in on the vote. And I will then hand over to Grace to review the results and review who we think, or rather who the literature around the world is showing may be suffering from acute COVID, from post-COVID-19.
Great, thank you for that, Maeve. So I see that the results have come in, and it's interesting to see that the majority of respondents have found responded to all of the above. And but it's important to note that 14% of you thought that there could be an alternative answer. And hopefully, as we go through the next slide, the answer will become apparent. So around June of 2020, the first publication that alerted the world to perhaps this developing condition or syndrome was published by CAEP, a group out of Italy, and they looked at 143 patients 60 days post-infection and found that these individuals still had a significant degree of symptoms, including fatigue, dyspnea, joint pain, and chest pain. Now, around the same time, because we live in a digital age, patients are also starting to organize themselves, and they start talking on social media. And I think long COVID will go down in medical history as the first condition that was really brought to the forefront of attention through a grassroots efforts by the patients who found each other with the similar symptoms post-COVID. And collectively, they call themselves. Now, here is the opportunity for yet another poll. What is post-COVID-19 condition, or PCC, as was stated off the top? Is it one, symptoms of acute COVID lasting for 2 weeks, post-acute infection, or positive test result, molecular result? Or is it 2, symptoms or complications of acute COVID present for 2 to 12 weeks after acute infection or positive test results? Or is it 3, symptoms or complications of acute COVID presenting at 12 weeks after acute infection or positive test result? The polls are now open, and please go ahead and make your selection. Great. So it appears that, again, the majority of respondents found the answer number 3 to be the most applicable answer, but still 12% of respondents thought that perhaps it could be number 2, which I think highlights the very problem that we do have in the field currently. Now, in general, the terminology has been a bit all over the place, with some people using the same terms but meaning really different patient populations. Post-COVID, post-acute COVID-19 is a general catch-all term of people having symptoms beyond the acute recovery phase of the first initial 2 weeks. More broadly, post-COVID-19 can be referring to patients with symptoms between 4 to 12 weeks post-infection. And then we have the newer term, post-acute sequelae of COVID-19, or PASC. This is a NIH term, and it is an ICD-10 code. And this is referring to complications at 12 weeks or longer. Now, more recently, the World Health Organization has come up with the official case definition, and they use the term post-COVID condition, PCC, and essentially referring to the same group of patients with persistent symptoms 12 weeks or longer. So essentially, PASC and PCC are interchangeable terms. So here's another poll. What are the most common symptoms reported in PCC? Is it 1, pulmonary? So this would include cough and dyspnea, wheeze, chest tightness, chest discomfort. 2, cardiac, so cardiac chest pain, palpitations. 3, musculoskeletal, so including myalgias, arthralgias. Or is it 4, neurocognitive complaints, sensory disturbances, with or without headaches? Here again, the poll is open with these 4 choices. And we'll give you all a minute to select your responses. So now there's quite interesting that while the majority of respondents have neurocognitive symptoms, there is an equal spread of respondents finding pulmonary, cardiac, as well as MSK as the most common symptom. So what do we know for sure in terms of the symptoms? Well, looking at a systematic review and a meta-analysis of a large number of publications that have hit the literature to date. Again, the caveat being all this literature, people are using very different definitions of post-COVID condition at this point, ranging from 2 weeks to 3 months after acute infection. But despite this heterogeneity in follow-up time, post-infection, you can see that the majority of patients are complaining of symptoms including fatigue, headache, neurocognitive and neurological symptoms like anosmia, ageusia, as well as symptoms, respiratory symptoms as well, chest discomfort, etc. Now, the limitation of what I just showed, while it was a large systematic review, it did have the complication of not having control groups and had a varying degree of different definitions of post-COVID condition. So here is a study where they try to be as controlled as they can, looking at a group of patients post-COVID and follow up at around 3 months' time. And what they found was looking at the prevalence of persistent symptoms at the 3-month mark. And as you can see, a very similar pattern emerged, where fatigue was the most common symptom described by patients, followed by dyspnea, as well as myalgias, followed closely by cough. Now, in terms of the types of systems and symptoms that have been associated with long COVID, this graph looks very similar to the picture of the symptoms involved and systems involved with acute COVID. And this perhaps is no surprise because all these different organs express the ACE2 receptors. And if there was acute infection in those organs, it stands to reason that there would be similar long COVID complications from the same organs. So what do we know about the development of PASC and what are the causes? Well, there are a couple of hypothesized etiologies for this. First of all, one school of thought is perhaps there's persistent inflammation, something akin to the lack of autoregulation after a pro-inflammatory response that the immune system just forgot to turn itself off. Or it could be that the virus exists and lays dormant in tissues and neurons, causing a low degree of inflammation to be persistent, something akin to varicella zoster. Another hypothesis is that perhaps there is molecular mimicry at work, that COVID-19 specific lymphocytes and antibodies have cross-reactivity to autoantigens, just like certain autoimmune diseases. And then finally, post-viral syndrome is a well described syndrome that can be seen after a number of viral infections, including SARS-1. Focusing now on PASC, what do we know, sifting through the massive literature? Well, due to some of the limitations, as I mentioned earlier, with regards to the follow-up and lack of control groups, it's been quite difficult to estimate the prevalence of PASC in a COVID-19 survivor. And so there is quite a range in the literature, but in general, there does appear to be a spread of about 5% to 30% of patients post-COVID is thought to develop PASC. Some risk factors that have been identified, including age, up to a certain age bracket, seems to have a higher risk of PASC, specifically those in the middle age range, 40 to 60 years of age. Female sex seems to be highly represented. Patients with PASC, those with an elevated BMI, those with a history of asthma, and those with certain symptoms during the acute illness. Now, if we were to be conservative with our estimation of the prevalence of PASC of, say, 10%, just to get a sense of what we are dealing with regards to this epidemic that lies ahead before us. If we take a 1.7 million cases in Canada, we're expecting that 170,000 patients then would go on to develop long COVID. Now, when faced with this new condition where we have rapidly accumulating mass of data, it's quite daunting to try to sift through all these different signals that's coming from our patient population. Many in the field have described and hypothesized there must be different phenotypes, that PASC is not a homogeneous population, but rather a heterogeneous group of patients with people describing distinct and separate symptoms. And so in general, there's two major ways to deal with such a situation. Either we take a hypothesis-driven approach, or we take a data-driven approach to analyzing the data. With regards to a hypothesis-driven approach, since we started our clinic in June of 2020, we have noticed a couple of themes emerge in our patient population. As respirologists, we do 6-minute walk distances on all our referrals, and we quickly noticed that there was a group of patients that have persistently reduced exertional tolerance. When examining these patients further, we found that these individuals did not have differences in their pulmonary function testing. We then tested these individuals with cardiopulmonary exercise tests, and we found that during exercise, there were no markers of pulmonary dysfunction, and we did not identify any cardiac limitations either. And thus, this phenotype of patients who have reduced exercise tolerance does not appear to have this outcome as a result of any pulmonary or cardiac problems. And that leads us to the hypothesis that perhaps muscular limitations, or in another sense, deconditioning, damage to muscle mass as a result of the viral infection, might be contributing to this group of patients. Another phenotype that has been hotly debated in the field is whether hospitalized patients versus non-hospitalizations will go on to develop different PASC phenotypes. And so we examined this in our patient population and found that Indeed, hospitalized patients did have more reduction in TLC and DLCO. And that's perhaps not surprising, as these patients are more likely to have been intubated and might have been exposed to mechanical ventilation and therefore perhaps barotrauma. However, what was very striking was this, regardless of their hospitalization status, both these groups had similarly reduced functional score, or the post-COVID functional scale score, the PCFS. Both had equally poor health-related quality of life metrics as determined by the EQ5D5L, as well as some mental health scores. Therefore, this leads us to believe that long COVID severity, or the impact of long COVID on these patients, would be same regardless of the severity of their acute illness. Now, we also took a data-driven approach. We partnered with our Department of Engineering colleagues and used artificial intelligence machine learning to look at the data. And we simply started with the question, patients presenting at 3 months at diagnosis, can we classify them in different groups based on their presenting symptoms? We chose 10 cardinal symptoms based on their frequency and importance in the literature. And we plotted these patients in essentially 10-dimensional space and asked the machine to look for clusterings of patient. Based on this analysis, we were able to identify these 6 distinct clusters. When we went to validate these different clusters by comparing them to known metrics of importance, like the functional score, the PFS, what emerged very quickly was that these different clusters were associated with different limitations functionally, as well as different degree of quality of life impairment. And that led us to propose the Edmonton Long COVID Severity Scale, where certain clusters were clearly associated with a mild phenotype, while other clusters were associated with a very severe phenotype where they had a dramatically reduced EQ5D5L and a very limited functional score of the PCFS. As a side note, this analysis also identified cluster 7, which happened to be the control group of patients who had essentially no symptoms by the time they were assessed in clinic. We have ongoing work in this area to look at further phenotyping of these different clusters and finding the different associations that might predispose patients to to enter into these different clusters. And very intriguingly, our early work has demonstrated that the most severe group is associated with a higher CRP at 3 months and seems to have an association with those that have pre-existing asthma. This work is in progress, and we hope to have further information on these different phenotypes and association at a later time. Now, with regards to treatment at this point, well, based on what has been reported in literature, there's really not much by way of solid, hard evidence to guide our practice. There are a number of different guidelines in the world that have suggested various approaches based on expert opinion. But again, there is no good evidence for anything that we are doing at this point. This BMJ flow chart is quite busy, but this is just to represent the recommendation for care of patients with long COVID in primary care. This long list, as you can see here, is really quite generic recommendations, motherhood statements to suggest smoking cessation or limiting alcohol or managing diabetic control. And so essentially optimizing one's health and supporting the patients is really all we have to suggest in terms of what we should be doing at this point for these patients. Now, in terms of guidance for the emergency department, there is even more of a lack of guidance here. So hopefully in the subsequent slides, we will give a sense of the common presentations and the management approaches that we have found to be helpful based on our experience, as well as based on the limited recommendations that have emerged in the field. But before we get there, just want to take a side note to discuss the challenges that many of these post-COVID patients face. As you can see in this word art, this is quite an exhausting and frustrating condition, and it ultimately is quite changing for these individuals. And by the time they show up in the emergency department, unfortunately, they probably have been around the medical block for some time. Many might have even had some very negative experience with healthcare providers, feeling that they were invisible, or gaslit is a common term used in the post-COVID community. And I think as healthcare providers, it is very important for us to be cognizant that these individuals are going through a physiologic event that we simply do not have the capability of identifying with our laboratory tests currently. But even if our testing is normal, it doesn't negate or undercut their experience. And I think our approach in managing these patients and communicating with them needs to highlight this point for them. So without further ado, I will hand over to Maeve, who can talk more about the specific symptoms and management.
Thanks, Grace. So to symptoms. These are what we've done here is we've gathered up what we think are the most likely or the most common symptoms that will present or that you may face in the emergency department, and some of the relevant strategies about them or to approach them. Each of these come with the caveat almost of considering in the context of long COVID, once red flags and appropriate alternative diagnoses have been excluded for the particular symptoms. So dyspnea and cough. Dyspnea, very common, and in the context of post-COVID or following COVID infection, particularly important to recognise or consider post-COVID organising pneumonia. Now, this is typically seen in the sort of 2 to 4 week time period from the original infection. And this time frame is very important because it's in this time frame that post-COVID organising pneumonia seems to be most responsive and indeed highly responsive to steroid therapy. And so on the next slide, we have CT images with the upper CT cuts showing you an example of post-COVID organising pneumonia prior to a course of steroids, and the lower cuts showing you the change seen after a course of steroids. And so it'd be a very appropriate referral to either pulmonary or general internal medicine for the ongoing management that will be needed for that particular diagnosis. In terms of cough, well, post-viral airway hyperresponsiveness is likely to be a top cause for a persistent cough. And so a short-term prescription or trial of a short-acting beta-2 agonist with or without an inhaled corticosteroid or a long-acting beta-2 agonist would be appropriate. Now, there is limited evidence with other viruses, or namely rhinovirus, that viral infection upregulates the expression of cough receptors on nerves. And this can be inhibited, this upregulation or expression can be inhibited by anticholinergics. And so it may also be reasonable to give a trial of Atrovent, for example. And indeed, if patients come to the ED having been given their Ventolin inhaler in the community and it's not working, Atrovent may be an appropriate alternative to try in that setting. And you also want to look obviously for triggers for the cough, for example, a postnasal drip that may be responsive to intranasal steroid spray, for example. And in the emergency department, what may also be a useful thing to do would be the so-called road test. Is this patient desaturating with exertion? And this is important as it may help direct the more appropriate patient pathway if rehabilitation is being considered. With desaturation, it may be more appropriate to go down a pulmonary rehabilitation route rather than a general rehabilitation route. So that's another very useful test to undertake in the ED if possible for these patients. What we also advise a lot of our patients to do, and indeed there is a plethora of information, and as Grace mentioned, the Facebook, the social media platforms are full of advice for patients as well. Locally, we use our provincial website, which has a resource page for patients, and this shows self-management strategies and is a good reference point for patients, particularly as they are able to be discharged home directly from the emergency department, even if they are pending referral or follow-up to appropriate specialties. Now, chest pain, I guess I absolutely do not need to say anything to this audience that that's a common ED presentation. And in the context of long COVID or post-COVID, there are a few important considerations. So firstly, an elevated D-dimer is well recognised in acute COVID infection, and indeed a mark of severity in acute COVID infection. And what we also now know is that elevated D-dimer is quite common in post-COVID patients. And so this may not be the most useful test in terms of helping to direct or narrow down your differential or help with your suspicion of pulmonary embolus. Having said that, retrospective studies in the post-COVID patient population presenting with dyspnea and chest pain have found PE to be present in about 5% or just under 5% of those patients. Chest pain is also often a feature of autonomic dysregulation, for example, postural orthostatic tachycardia syndrome. And this is something that is also increasingly being reported, noted, observed in post-COVID, long COVID patients. And so it would be worthwhile to do an erect and supine set of vitals. And if you suspect this as a cause for their chest pain, advice on increasing fluids, their salt intake, compression stockings would all be appropriate, as well as a referral to either neurology or cardiology as per local protocol. Our local protocol is to neurology. However, other cardiac complications are well recognised in long COVID, myopathies, dysrhythmias, myocarditis, pericarditis, and with appropriate investigation, these all genuinely warrant a referral on to cardiology for further evaluation and management. And again, just on our next slide here, what is concerning, I was going to say interesting, but for what is also perhaps concerning to note is that there is growing evidence in the literature that patients up to 1 year post-acute infection with COVID-19 seem to be at an increased risk of macrovascular complications, as you'll see from the chart shown on the slide here. Although admittedly this study was done in a slightly older population in the 60 to 65-year-old category, but concerning nonetheless, and I guess increases our awareness or our suspicion for patients presenting who have post-COVID and signs suggestive of macrovascular disease or acute illness. And again, we've just shared, before we get to the self-help, I was going to say we're going to share the self-help strategy from our AHS page as well. But importantly as well, with regard to chest pain, When no obvious etiology or cause is found, and this tends to be very much a pleuritic or indeed a neuropathic type of pain that patients are describing, these drugs that we've listed here are ones that we have found within our post-COVID clinic patients to be helpful. However, particularly with regard to drugs such as gabapentin or the tricyclics, the adverse or potential adverse effects from these drugs can obviously worsen other long COVID symptoms that may be present. And so just to bear that in mind, if somebody has got quite striking fatigue or brain fog or neurocognitive symptoms, adverse effects from gabapentin, which may be helping their chest pain, may be worsening their neurocognitive symptomatology. So just to consider that. And here we've shared the AHS resource with regard to what they suggest to patients who are experiencing not just chest pain, but very much this myalgia type of pain. So fatigue, I think we've established that this is very, very prevalent in this patient population. And patients will typically say to us, it's a roller coaster of good days and bad. They tend to have one good day, and following this, they're set back, absolutely floored for the next 3 to 4 days. What is emerging is that there are a lot of sleep disturbance issues associated with fatigue. So a good sleep history or consideration towards sleep disordered breathing is important. Again, this is ultimately going to require a multifaceted approach in terms of management, and patients really need to be linked in with their family physician, their primary care physician for ongoing review, support and follow-up. But specifically, we would suggest exploring mood component to the fatigue, as well as sleep disturbance, sleep hygiene, or considering investigation for sleep disordered breathing itself. So again, self-help strategies for patients in terms of managing their energy and advice on basic sleep hygiene can be useful in this setting. So Grace and myself hesitated slightly as to whether or not to include this slide, thinking, would this be likely to turn up in your emergency department? And then we came across patients who locally had indeed gone to the emergency department with purely these symptoms of loss of taste and or loss of smell. So obviously these are classic hallmarks of acute COVID infection, but we know that these symptoms can persist really for several months following the acute recovery from the infection. And patients describe it in various ways. And really, ultimately, again, with the caveat of, considering red flags or alternative etiologies, management comes down to sensory retraining. So exposure to stronger smells, stronger spices, considering color vibrancy, texture is all important. And again, this is something very much that patients from ED can be directed to their family physician for support, and also again our local provincial resource has some good advice for patients in terms of managing these symptoms. Finally, we put in a quick note on the management of headache. Again, obviously once red flags or alternative diagnosis are excluded, our neurologists locally have been advising strategies that patients in our post-COVID clinic here in Edmonton have found very beneficial. So firstly, considering, again, mood component and sleep hygiene. Following this, vitamin B2 and or magnesium citrate, a trial of these for 3 months or so to see if they are beneficial in preventing headache has been anecdotally reported by our patients to be very helpful. And again, for those who may well have a component of sleep issue contributing to their symptoms, when you're taking their history, melatonin at a dose between 3 to 10 milligrams nightly may also help be preventative for their headache. And so to summarize our talk, our presentation tonight, I think there is a significant burden on many levels, an individual level, societal level, and economic level, not just from acute COVID-19, but now from what we're seeing, the tip of the iceberg perhaps, of post-COVID-19 condition. Identifying patients who are at risk is going to be very useful, very helpful. And so work in terms of biomarkers and identifying who might be at risk is ongoing work that will be research work that will be helpful. But I think it's clear that both non-hospitalized and hospitalized patients can suffer from post-COVID-19. And the clinical trajectory for the patients remains to be seen at the moment as we worldwide try to research and understand more in this evolving condition. And that's going to affect our resource allocation going forward. But importantly, it should have perhaps also affect our public health messaging as we go forward, that people who contract acute COVID-19 infection may well be left with long-term persistent symptoms and complications. And so with that, we'd like to acknowledge our whole post-COVID clinic team here in Edmonton, both physicians, we're mainly pulmonologists, but we have support from cardiologists, rheumatologists, neurologists, immunologists, hematologists, as well as our admin and leadership. And we'd like to ask if you have any questions for us.
We do have a lot of questions. Dr. Smith, Dr. Lamb, thank you so much for such an informative presentation. You obviously are leading cutting edge developments in this condition. And on behalf of CAEP and the over 50 people who joined this session, I just want to thank you for such a clear and well-organized presentation to shed some light on a very complex matter. A big thank you as well to Dr. Abdullah at UBC Kelowna, who's helped put this whole session together. I think, you know, it looks like we've got lots of questions about pulmonary embolism. And what we've noticed is that in our own data here in Alberta and Calgary and in Alberta is suggesting a significant uptick in CT imaging in the emergency department. We haven't quite teased out what exactly is going on, but I suspect COVID-related investigations for PE specifically, whether it be in the acute phase or post-COVID phase, is driving it. So, you know, I can appreciate that D-dimer continues to go high in post-COVID. But is there some evidence that having it be very low might be useful in ruling out PE? And then there was just another question as to whether we can identify a particular population or subgroup of post-COVID patients who might be at particular risk of PE. So I don't know if that's for Dr. Lamb or Dr. Smith. Grace, do you want to start?
Sure. Yeah. So you raise excellent questions, and unfortunately, we don't have much to offer by way of evidence, even if it's cohort or retrospective data. Certainly does sound like a excellent question to do research on that Dr. Lang, I think you're well set up to look into. But I think at this point, borrowing evidence from the general population, I think if the D-dimer is negative, there isn't any evidence to suggest that that would behave any differently in this patient population. So I think you would be well justified to feel comfortable with the negative dimer without having to do advanced further imaging after that. With regards to how to tease out which is the patient population who might have a PE, I think one of the things is that looking at the clinical picture, if there's obviously tachycardia in conjunction with dyspnea and hypoxia, those certainly would be features that you would think we should investigate for acute PE. In our clinic, I often send people for VQ scans looking for more chronic clots, but this is driven a lot by exertional desaturation, that I can't explain otherwise, as well as certain PFT abnormalities like isolated reduction in DLCO. So I think within the emergency department setting, especially if you think that somebody's oxygen dips on exertion, that would be another, I think, additional red flag that perhaps these patients need just to be investigated a little bit further in context with symptoms that is consistent with possible PE. But a more rational approach to identifying these patients and what their phenotype is like if they present that way is difficult to tell at this point.
That's super helpful. Dr. Smith, does being vaccinated and does the whole breakthrough infection piece, does that reduce the likelihood of post-COVID or at least mitigate its severity? And we may not know the answer to that yet. So it seemed like an interesting question that came through.
So that is a great question, and the reason Dr. Lamb and myself are smiling is this is a question that we have been bouncing around and looking at our clinic population to see if we can try to address it in any way. I'll probably let Grace speak to it a little bit more in terms, but I think. Unfortunately, I think this is going to apply to a lot of our answers. We all have these questions, and the sheer evolving nature of post-COVID, similar to the acute infection, the trajectory is unknown. The research is not yet there. The answers aren't there, but we need these answers. But no, it's a great question. But I'll let Grace explain a bit more.
Yeah, we just had a discussion about this on Tuesday, and I had gone into our database and looked over the weekend about this very question. And what I can say is that up to this point, we've seen almost 500 patients. And caveat being, then we look at the patients seen this year because the vaccines were really only available since January. And later than that, if we talk about what is publicly available to the general public. But if we looked at the number of referrals from this year and how many of the patients were referred to the clinic with long COVID symptoms who had infection after being vaccinated by 2 doses of the vaccine, we have 2 patients. And when I looked at these 2 patients further, one of them had a pre-existing condition with that was terminal and palliative, and so had a shortened life expectancy. And this condition was a pulmonary condition, so it's not clear whether this individual really had long COVID or whether they simply had symptoms as a result of their underlying terminal condition. The other individual was actually a healthcare worker who had their vaccination early in second dose in February and had unfortunately acquired the infection in September. What happened to this individual was by the time that they were seen in clinic, and they weren't actually even quite at 3 months when they saw us. So technically, not yet meeting the definition of PCC or PASC, this individual actually was deemed by the assessing physician to actually not have persistent symptoms anymore by the time they saw us in clinic. So obviously, this is a biased sample. These are case reports, but based on these two cases and the fact that we've only gotten 2 individuals certainly raises the possibility that perhaps those that have been vaccinated may have a less likelihood of developing long COVID. And even if they did, it sounds like it's pretty mild.
That's brilliant. Thank you. And by the way, I think we all love the squealing in the back. That's so cute. We've got some questions about the optimal use of biomarkers in PASC, whether it be CRP, ESR, or D-dimer. How would you recommend an emergency physician navigate that, both in predicting PASC or maybe diagnosing PASC?
So we don't have any definitive markers for diagnosis as yet. What we have been doing in our clinic, so we started our clinic back in June 2020, and the clinic has evolved significantly since then. And along with that, our investigations protocols, what we started off doing is a standard set of laboratory tests, which was informed by not just ourselves as pulmonologists, obviously, but we had immunology input into it as well as hematology input into it. And the standardized test their standard list that we do now is quite different in a lot of ways compared with back in June 2020, as we've understood that some things seem to be less helpful than others. What we do check, and everybody referred to our clinic before their first visit, if this is of any use or utility within the ED, we do check inflammatory markers. We do check the CRP. We also check CK because we do see a lot of myalgias. We also have been added on quite recently, and so I'm not sure if we're going to see a particular signal from this, but early morning cortisol. And obviously some of these aren't necessarily, going to be diagnostic. They're going to be excluding other things as well, or important things for us to consider in the clinic setting. We don't routinely do TSH, but there are other clinics that we're aware of who do check that as well. And that's in addition to CBC differential, creatinine. We have noted quite a bit of renal impairment at the 12-week mark, and in some people we don't even have the premorbid any premorbid recent labs for a comparison, particularly for the non-hospitalized patients. So the answer to your question is no, we don't have. There has yet to be identified a marker that can be used for diagnosis. I think the tests that we do, and certainly within the emergency department, are very much either to exclude other diagnosis or support the route that you're going down with your suspicion for post-COVID by exclusions or by looking for other signals that might suggest that this is post-COVID related.
I think we may have time for a couple of closing questions. One of our audience members is curious about the mentioning of the use of short-acting beta agonists in post-viral cough in this setting, and was asking if you could elaborate on that perhaps. Is that the initial approach? Is it possibly combined with inhaled corticosteroids? How would you suggest we manage, because we will be seeing, and we do see patients with debilitating cough in this context, whether it's PASC or just early bronchial reactivity?
So I tend to favor trialing an anticholinergic in this setting for the post-viral airway hyperresponsiveness. And that is based on very limited evidence, admittedly, although there is some there. I think often in this setting, so I also come from a biased perspective of usually having the luxury of some spirometry before me. But, I think if you've excluded your important things, you've got a normal chest x-ray sitting there, and often patients will have already been prescribed a short-acting beta-2 agonist in the community. Part of me thinks it's much akin to other acute infections where we say 72 hours with antibiotics, 3 days without. Except that with post-viral cough, which can persist for months afterwards, post any virus and viral and upper respiratory tract viral infection, it can be months following this. And honestly, I don't think there is a particularly right, excuse me, or wrong answer here. I think a trial of PRN Ventolin would be as appropriate as a trial of QID Atrovent. And I think the important thing is that they are followed up. And that follow-up, I think, is appropriate with family physician. And, if comfort levels are then exceeded with the longevity of the cough, then a referral to pulmonary is also very appropriate. So I don't think there is really any great or good evidence behind either approach, particularly if you don't have spirometry sitting in front of you. Obviously, if you've got spirometry and post-bronchodilator values as well, that you're going to go down quite a particular management route. But allowing for the fact that you likely don't have that in the ED setting, with a normal chest x-ray, not hearing any wheeze when you're listening in, and you think this is post-viral cough, honestly, there isn't really a right or wrong answer, but ensuring that there is follow-up there for them is probably the most important thing. And I think in terms of a trial of inhaled therapy, you probably have everything to potentially gain versus not a lot to lose.
Those are great pearls. Last question I think we'll have time for is about PASC and pregnancy. Does it happen? And are there particularities, or even in the postpartum, but are there particularities to managing PASC around the pregnancy and postpartum period?
Maybe I'll take that question, just because I have seen one individual referred to us who was pregnant at the time, and so definitely this patient caused me a lot of worries and concern. Because a pregnant patient already is at a heightened risk for clotting, and post COVID-19, I worry whether that compounds their risk of clots, and so definitely in this patient population, in this individual, I was quite concerned about these particular parameters and these issues. So what I can say in this patient that I did see is that after pregnancy, things went back to normal. So, N of 1, I can't really make heads or tails with this. There's no case series reported even in the literature about this topic, as there is about acute COVID in the pregnant patient. But there are definitely lots of consideration, because if you think about all the symptoms of PASC, brain fog, fatigue, shortness of breath, that's kind of pregnancy as well. And so, you know, this individual, when I met her, she was in her late third trimester. And so how much of this was just the fact that she was late third trimester and how much of it was past, it was really hard to tease out. And I followed her closely, followed up with her after the pregnancy, and only with time was I able to say, well, since everything got better after the pregnancy, it probably means that there was no past. But during that period, absolutely, it was very hard to tell. And all I could say was rule out the life-threatening things. I sent her for a ultrasound of her legs to make sure there's no clots. I tried to convince her to get lung imaging, but she declined that, even a chest X-ray. And have that close relationship with her OB, just to say, this is what I'm worried about. If you see anything untoward, please think about these possibilities. And then following up closely afterwards, from those of us who have that luxury to follow up.
That's wonderful. Hey, thanks to both of you for brilliant presentations, spending all this time with us, and really doing a great job on all these tough questions. And thanks as well to those who submitted. I'm going to pass things over to Hassan for some final comments.
Thank you, Dr. Smith and Dr. Lam and Dr. Lang and everyone involved in setting this wonderful presentation up today. I just wanted to remind all our audience that we will send evaluations and certificates tomorrow, and we hope to have your feedback on how to make this a better presentation in future, and like what we did really well and what we can continue doing well. So that's really all I had, and thank you for taking time out tonight to join us.
Thank you, everybody.
Thanks, everybody. Have a great night.
Thank you.